came in to try and help, it was almost as if we were actually bringing Ebola to that region of the world. So what happened? There were 28,000 cases, 11,000 deaths. But one thing that was proven, and we did it in Liberia, the French did it in Guinea, is that we proved that you can actually do research in an area of the world where there is an ongoing infectious disease outbreak. And we did a group of studies called the PREVAIL, which is the Partnership for Research on Ebola virus in Liberia. We did vaccine studies, which resulted in a successful vaccine. We did therapeutic studies with ZMac. We did epidemiological studies. We did natural history studies. And we're now in the middle of a bigger vaccine study. That was the Ebola over there. But something else happened that taught us a lesson. And it's how we view risk in our society. And that was when the inevitable happened. And we knew it was going to happen. It had to happen. Somebody got on a plane in Monrovia. His name was Mr. Duncan. He was a Monrovian, a Liberian. He lived there. He got infected by his sister. The incubation period being up to 20 days. Didn't have any symptoms. Got on a plane, landed in Dallas. Went there for a few days, started to feel ill. Went to the emergency room in Dallas. Presented with a fever, malaise, a flu-like syndrome. You know, if there's one thing that you learn in medical school, that when someone comes in, you always ask them what their travel history is, where you've been lately. Ebola was all over the newspapers. It was giving me an antibiotic for sinusitis and sent home. He went home and he got really sick. And then he went to the emergency room, this time in extremis, and was immediately admitted to the ICU. And this is an interesting story because you can understand in real life how it happens. He comes into the emergency room, goes to the ICU, and they start taking care of him the way they should be. The only trouble is, 2 days went by before they realized he had Ebola. And 2 of the nurses that you all know about, who bravely took care of him, got infected. And that's when all hell broke loose, because the papers then said Ebola is in the United States. Even though, as much as I said it, and as much as Tom Frieden said it, you don't get infected with Ebola until you get direct contact with the body fluids of a very sick person. So someone who's asymptomatic walking around, or who isn't sick, you're not going to get Ebola. Nonetheless, and this was a USA Today article, fear spreads faster than Ebola. So what we did is that we established, interestingly, because we had already been doing that, the capability of taking care of Ebola patients in intensive care. It's an interesting concept because you have to take care of someone who's deathly ill, but you have to do it in BSL-4 conditions. So 3 areas were set up, one in Nebraska, one at Emory, and our own at NIH, because we had built a special clinical studies unit. It wasn't because we were anticipating an Ebola outbreak. We did it for the possibility of taking care of people who accidentally infected themselves when they were doing research. So we had a whole system of flying people in and taking care of them. So we were well prepared for that. So we first took care of Nina Pham. Some of you may remember, a very famous nurse who was infected. And here's a picture of, we took care of her for a couple of weeks, of my discharging her publicly in front of the NIH Clinical Center. This made the front page of the Washington Post. And the reason I put my arm around her and did that publicly is because there was a terrible stigma against people who had been infected with Ebola. Not only about people who've been infected with Ebola, but by the doctors and the nurses that were taking care of people who were infected with Ebola. It's really bizarre, but it actually happened. And I'll tell you a story about that in another second. So that was one of the cases, but the one that I remember, and I just want to relate to you in a minute or two, the experience we had, because it really emphasized what you can actually do with the proper resources. About a month later, we were told that one of Paul Farmer's people in his Partners in Health, because Paul had set up a unit in Sierra Leone taking care of Ebola patients. One of his physician's assistants got infected and was brought over in emergency to be taken care of by me and my crew at the NIH. So we flew him in to Dulles Airport, ambulance with police escort, took him to the NIH campus in Bethesda. And here is a picture of my people on my team and my group waiting for him at the back entrance of the NIH Clinical Center. And we were very well prepared for this, and this is an example of everybody dressed like that to take him in and bring him to the ward. So the drill is, and this was practiced multiple times, there are two teams, one an infectious disease team, one an intensive care team, about 7 to 10 nurses rotating every 12 hours. With the rule, you can only be in a room for 2 hours at the most because you get tired and then you make mistakes. So here's an example of what we had. So this is me and one of the people in my group, Dan Chertow, who had just come back from Sierra Leone, in which he took care of like 350 patients, so he really knew what he was doing. And I was the infectious disease person for that shift. So a shift is 2 hours, so you do 2 hours on, 2 hours off, 2 hours on, then you do that for 12 hours, then you go home and do whatever you want to do. But you have to take your temperature every 12 hours. So here we are getting ready to go in, and here I am suiting up, getting ready to go in, and I have to say, and this is a picture of Dan and I, you can't recognize us because we're all suited up, taking care of this young man who was a physician's assistant, who was about the sickest patient that I've ever taken care of, which tells us that if you have the capability of giving intensive care, this is not a 90% fatal disease. All the textbooks say 90% fatal. It isn't. But you don't have generally the capability of intensive care with these individuals. The good news is, believe it or not, believe it because it happened, we reported it in the Annals of Internal Medicine, that this young man who was as close to death as I've ever seen anybody, 4 weeks later walked out of the hospital with his parents completely well and is now back home, again taking care of patients. So the final one that we had, and we were in the middle of this when we did it, was Zika. So when Zika first came about, another interesting, it's so fascinating, I mean, if you're in our field, why it's so exciting to see, because Zika came out of nowhere. No one expected Zika. So when it came, the New England Journal asked me to write a perspective on it, so I wrote a perspective, and I entitled it, Zika virus in the Americas, yet another arbovirus threat. And the reason I said yet another arbovirus threat, because if you look historically, over the previous 20 years, we've had a number of arboviruses, including flaviviruses and alphaviruses. Dengue, West Nile, chikungunya, Zika, the resurgence of yellow fever. How did it happen? Well, as you know, Zika was discovered in 1947 in the Zika forest of Uganda, hence the word Zika. The first human cases were not detected until 1952. And then what happened is it went under the radar screen in Africa and Asia, and the first outbreak was 2007 in the Yap Islands of Micronesia. Goes off the radar screen. 2013, the second outbreak in French Polynesia. No one was paying attention to it because the number of cases was small enough that we didn't realize what the real threat of Zika was. Then when it hit Brazil, another perfect storm. You had a large country with a lot of people, a lot of mosquitoes, and a completely immunologically naive population that had never seen Zika. They'd seen dengue, but dengue antibody is not cross-protective against Zika. So you had an explosion of cases, as shown in this green line, which was the cases in South America, the red in the Caribbean, the blue in Central America. And you say to yourself, why did we get surprised by this when it came to the real devastating effect? And that is because, in general, Zika is a relatively inconsequential infection. 80% of people are without symptoms. Those who have symptoms that last for a few days, headache, malaise, rash, conjunctivitis, myalgias, and arthralgias. It was only when you reached a critical number did you then see the real problem with Zika. And that was the marked increase in microcephaly when women got infected during pregnancy, particularly in the first trimester. And thousands of babies were born not only with microcephaly, but what we're starting to see now in follow-up studies is that a baby could be born with a normal-sized head, but when you look later on, they wind up with other problems: vision, hearing, subtle damage to the brain, interfering with the developmental landmarks. Not only babies, but there are some adults who have problems, such as Guillain-Barré that we see now, as well as a rare case of encephalitis, transverse myelitis, etc. Now, what has that got to do with the United States? Well, something that I didn't realize until we checked on it is that the amount of travel between the United States and Zika areas, 216 million people a year go back and forth between the United States and either Central, South America, or the Caribbean. That's an important number because when I briefed the Congress, one congressman asked me, the way we can keep Zika out of the United States is don't let anybody into the country who's been in the Zika area. I said, well, that's going to be good. That'll be 216 million people that you're going to prevent from traveling. So that doesn't work. But when you have travel, you have travel-related cases. And that's what we saw, and that's what we still see a little bit of, is people who were infected in South America or the Caribbean came to the United States and got sick in the United States. That's a travel-related case. There were about 5,000 of them, but Puerto Rico had almost 500,000 infections. And it's inevitable when you have a travel-related case to come to a country that has the right mosquitoes, and we have Aedes aegypti mosquitoes certainly right here in New Orleans, that's for sure, but in Florida and in Texas and other places, then sooner or later, you're going to have a local case. And what's a local case? A local case is when someone never left New Orleans or Florida or Texas. Somebody gets infected elsewhere, comes here, gets bit by a mosquito, bites me, and then I get infected. And in fact, we had over 200 infections in Florida and a cluster in Texas. Sexual transmission very much complicates things because we now know, as many other viruses, is that Zika virus can last for weeks in the semen after you've cleared it from the blood. And that's the reason why the CDC recommendation, if you're a man and you're in a Zika area and you go back home, then you should have protected sex for at least 6 months because you may inadvertently infect your sexual partner who, if she were pregnant at the time, you could really have a problem with that. But fortunately, Zika has essentially died down. And as of just a little while ago, a few months ago, the CDC declared it over in Florida, and Puerto Rico has declared that the Zika epidemic is over. Unfortunately for Puerto Rico, they have a hell of a lot more problems right now than Zika, but it's going to come back because of the standing water that they'll wind up having. But just a word on the response. As with any other outbreak, we respond with a number of countermeasures, particularly a vaccine. And we have a vaccine now among 4 or 5. It's the DNA vaccine, the one on the top, which was started in a phase 1 trial in Bethesda, and then is now currently, as we speak, going into a phase 2 trial. The point I want to make about the Zika vaccine is that it was a landmark that got no attention in its platform technology, which means if you have a DNA plasmid that you can readily insert a Zika gene, an Ebola gene, a yellow fever gene, you can save months to years in vaccine development. And with Zika, look at the bottom, the time from when we sequenced the virus to the time it went into a phase 1 trial is less than 4 months. That's the fastest in the history of vaccinology, of getting the sequence of a virus and putting it into a phase 1 trial. And that's where vaccinology is going over the next several years. We're in this phase 2 trial. It's ongoing, as I mentioned, in South America, in the Caribbean, and in Texas, actually. So that was the story that I told. So we had 5 administrations, a number of emerging threats, a different kind of lesson almost with each threat, the little subtle differences that you learn. So the real question is, what about the next administration? And the big question of what's next? And the answer is, if you're listening, is that we don't know. We just don't know because it's so unpredictable. What can happen? Will there be a return of Zika, particularly in the wake of hurricanes, which have now devastated infrastructure and will leave a lot of standing water? We don't know. Remember, you ask yourself, if somebody asked you 4 years ago, what is Zika? I mean, I'm an infectious disease guy. I wouldn't have known what it was. I mean, I had heard of it maybe some time ago, but I never paid any attention to it. The same thing could happen with names like Myaro and Oropouche. So how many of you are thoroughly familiar with Oropouche? Not really. But it's out there. They're transmitted by mosquitoes, they're transmitted by midges, and they're in areas that travel back and forth to the United States. So, I mean, as science fiction as this sounds, it isn't. We're having a big problem with tick-borne diseases right now. I mean, obviously, Lyme disease is big time, but there are also a number of other tick-borne diseases that we need to pay attention to. Internationally, the ancient disease of cholera is still around, a big outbreak in Yemen. And the one I want to close on is important. The threat of a pre-pandemic turning into pandemic. And we're right now concentrating on a virus called H7N9, which is a chicken virus. It jumps from chickens to humans. It doesn't efficiently transmit from human to human. However, there's always the threat that it will evolve to do so. And in fact, we've been following this since 2013. The season comes, you get a bunch of infections in humans, chicken to human, but not human to human. 2014, 2015, 16, but look at 2017. That now, the virus that we made, the vaccine that we made in 2013, the virus has evolved so much in 2017 that it's non-protective. So all the money we invested to stockpile a vaccine based on the 2013 flu is relatively useless. So what does that tell us? It's about time that we need a universal flu vaccine and stop having to chase the flu. So we're making a major investment. We had a workshop just a few months ago in June. That's David Baltimore and Gary Nabel and I at a workshop trying to put together, and we did a research agenda, which we're going to be publishing next 2 weeks from now in Unity, about the pathway to the universal flu vaccine. So, in summary, what do 3 decades of pandemic threats teach us about the future? And it's what I think is obvious from my discussion. If history tells us anything, it's that this new administration is likely to experience at least one infectious disease crisis of significance, and maybe more, as the Obama administration experienced. So the lesson learned, we need global surveillance, transparency and communication, infrastructure, coordination, adaptable platforms, and what I've been arguing for some time now is a stable funding mechanism like a public health emergency fund. And at the end of the day, the one truism that we can all take, which is why the discipline of infectious diseases will never go away, despite the fact that it's the lowest paying discipline in all. Emerging infections are a perpetual challenge. They have always been with us. They're with us now. And just as I tried to impress upon the incoming administration that they will continue to be a threat as sure as we're standing here. Thank you.
Great. Thank you, Dr. Fauci, for a wonderful presentation. We have a few minutes to take a couple of questions. I'll just pass the mic around. Please just, I think you know you, but you might just identify yourselves before you speak.
Hi, I'm Bob Hyatt from UCSF. Great presentation, very exciting. A lot of us in the room have had experience both with the NIH and the CDC. And I wonder what principles or rules you have adopted over the years to decide what's your responsibility, what's the CDC's responsibility, and has that changed over 5 presidents?
You know, that's a good question, because sometimes people get confused as to about who does what. I think the recent 8 years when Tom Frieden was the director of CDC, and I'm in my current position for a long time, that the CDC's primary responsibility is identification, surveillance, and indication of an emerging outbreak. To do the original identification and the diagnosis, etc. The NIH's sole responsibility is the basic and clinical research to define pathogenesis, natural history, and to develop countermeasures. So it's more of an epidemiology, surveillance, disease tracking, disease response with interventions, therapeutics, and vaccines. So it really is a very smooth synergy between the two. I mean, obviously it doesn't always work that way, but it's meant to work that way, and it worked really well in the last 8 years.
Thank you, Melissa.
Melissa Perry, George Washington University. Thank you for that excellent presentation. I felt as though it was such a wealth of wisdom and knowledge when it came to understanding infectious disease over the last 30 years. And I can see it as being very inspirational for the trainees in this room as well, who are working on becoming epidemiologists. And I'm sure that so much of the history that you presented